Good afternoon, one and all. At the outset, I would like to thank Dr. Rima and the organizers for giving me this wonderful opportunity. Mistakes in infectious uveitis. Let me start with the first case. This was a 42-year-old lady who presented with pain, redness with a keratouveitis, uveitis, and the resident started the patient on topical steroids. And within 3 days, when the patient came for reading of the Mantoux, there was a very violent flare-up, and we did a scraping and sent for the lactose cotton phenol blue. And the surprising history that was missed was the native treatment for the injury with the vegetable matter with the patient confounded initially. So, Aspergillus fumigatus was identified, and we have to be very careful in asking a delicate history, and fungal uveitis can flare up. So, such even an anti-uveitis can cause problem in an infection scenario like India. Sometimes we are faced with some negative response, and we get a feeling like this. So, let me shift gears. This was an 18-year-old young boy who presented with pain associated with Gibbs lateral headache and high grade fever of 5 days duration. On examination, anterior segment was apparently normal. The vision in the left eye was reduced to 1 by 60. There were very faint cells in the left eye, and the fundus showed dull looking RP like lesion, and the media was fairly clear. And we were suspecting possibly a possibility of viral uveitis and started the patient on antivirals. After reading the Mantoux oral steroid was started. What surprised us was the other eye vision also got involved, and we ordered additional tests like HIV, TPHA, and this was appearance with multiple subretinal lesions involving the macula, and there were RP modeling. And the OCT showed a full thickness hyperreflective lesion temporal to the disc. And there was a marked progression of the foveal thinning within a short span of say, 5 days to a week. And fovea has gone for thinning in atrophy. And the FFA also showed a few leaks in the early and late frames. And the patient was lost to follow, and he presented back to us after a month. Again, the macula was again the thinning increased, and there was a totally disorganized architecture of the layers of the retina with some fluid collection. We ordered additional tests like dengue, chikungunya, HIV, HPSCAG, and wheel Felix toxoplasma. Everything came out negative. So we did include this measles IgG, which really came out positive, and sudden progression of macular thinning and disorganized OCT. So the diagnostic criteria of SSP include the rising titers of antibody titers plus or minus the CSF titers. So what is not feasible is the brain biopsy, but the CSF tab with the raised gamma globulin or oligoclonal glands could also help along with the EEG and the clinical presentation of myoclonus. So the drugs used for treating SSP include a whole lot of amantadine, cimetidine steroids, interferon alpha beta, uh, isoprinosine, immunoglobulins, and ribavirin. What is interesting is the combo of intraventricular interferon alpha plus oral isoprinosine is the best treatment that has been published. And this is one interesting article where they said the age of onset of SSP less than 12 years and the disappearance of the periodic complexes, the tendency of normalization in the EEG, and progressive increase in the measles titer all are associated with favorable outcome. Normally, SSP has got a poor outcome. When you encounter all these pointers, we can be a little happy that it has a favorable outcome. So the point to delineate SSP inflammation is little or sparse vitreous inflammation, like in our case, or involvement of the retinal vessels or the satellite lesions. They help in delineating SSP from top zone visits. So clinically, when we encounter a lack of steroid response, we need to keep all these things in mind. Are we dealing with a possible very violent infectious uveitis, or it could be even non-infectious uveitis presenting in an aggressive way, or fungal uveitis, or it could be a masquerade or in a metabolic masquerade or an ocular ischemic syndrome. So we should keep all these options open and evaluate in those directions. So sometimes we get this conflict between clinical sense and investigations, and we are in dilemma to proceed. This was one such case where a 55-year-old lady present with pain in left eye of 5 days duration, associated with the characteristic tubercular history of evening rise of temperature and night sweats, which was initially missed, but subsequently elicited. There was no specific history except that there was a history of type 2 diabetes and oral hypoglycemics. The anterior segment was apparently normal. The posterior segment in the left eye showed sort of choroidal or associated with the retinal lesion, and the B scan showed an RC elevation associated with shallow retinal detachment. The OCT here showed a focal ISOS loss, and the perilesional and the perimacular OCT showed ellipsoid zone loss along with SRF, and there is a very characteristic RP elevation, so associated with the retinal detachment. So we thought that we are dealing with the left eye posterior uveitis and possibly had secondary tuberculosis sarcoid in our mind, along with an amelanotic choroidal melanoma and solitary idiopathic choroiditis because of the unilateral presentation. And we were keeping all these options in mind. And after 3 days, this was a fundus picture, and we got all the reports, and the ESR was little elevated. MAN2 was 0 millimeter, and we thought that possibility of tuberculosis is very little in that patient. So we did an FFA. It showed a punctate hyperfluorescence in the late venous phase. In the late phase, there is an increased hyper. In the late venous phase, we also encountered a punctate hyperfluorescence and an increased hyper in the late phase as well. So the other findings were the hypofluorescence and the hypo turning into hyper adjacent to the original lesions. We ordered an HRCT scan, and it showed a ground glass opacity. In the present scenario, we will be thinking in terms of COVID, but the radiologist gave us that all these could point towards a compensated left cardiac compromise and interstitial lung disease. And the treatment was the oral steroids was started at 50 milligram, and we ordered for an MRI orbit because we still had that secondaries of choroidal melanoma in our mind. And surprisingly, the vision reduced to 6/24. Then there was increasing configuration of the lesion along with subtle hemorrhages around. This MRI orbit gave us a clue that we are dealing with possible early uveal melanoma. So we were keeping our hands crossed. Are we dealing with non-tubercular etiology or an early uveal melanoma? These can also show there is an increased RCS elevation, which was initially captured as well. Along with oral steroid, you see a distinct progression of the lesion, which is seeping downwards. And we repeated the FFA, and it confirmed that all these there is a definite progression along with seeping of the dye towards the inferior arcade. And we also did a PCR, which showed there is a possibility for nested PCR MPB64. So with that in mind, we stopped the oral steroid and initiated anti-TB treatment. Oral steroid was restarted after a gap of 5 days, and look at what happened. There is a marked fibrosis, and there is a marked regression, and the OCT also showed that there is a improvement in the neurosensory detachment, and all these RP elevations has reduced. The interesting fact about this third case was there is no pointer for tuberculosis, MAN2, but for the history, and the PCR was definitely helping us to reach the diagnosis of tuberculosis. And MRI in FFA can sometimes confuse us, and as in this case, the MRI pointed towards choroidal melanoma, and metastasis was also pointed based on the FFA picture. PCR report takes 3 weeks. Sometime in those 3 weeks, we need to be very careful in initiating ATT. And this was one interesting article again from PG Group, where they published a similar masquerading TB versus melanoma. And the point of difference with our case was the systemic features of tuberculosis were characteristically absent except for the history part. So the rest of the findings are similar. And the TB, I'll finish in few slides. The ocular tuberculosis masquerading as ocular tumor is commonly reported, and they have concluded that the ocular tumor can have various presentation. And this is my last slide. The treatment speaks 1,000 powerful words, and need to pay attention to listen to those powerful words, and don't believe only the investigation, whether it is MR, CT, or whatever it is. Be clinical. Thank you so much.